So welcome back to another edition of the Hart2Heart Podcast. And my guest today is Dr. Brian Lenzkes. Dr. Brian Lenzkes is one of my favorite follows on Twitter. I've been following him for a long time. He's an internal medicine doctor. He's also the host of the Low-Carb MD Podcast and Life's Best Medicine Podcast. So, Dr. Lenzkes, welcome to the show.
Hey, thanks for having me. It's great to be here. I'm glad we can make it happen. Getting two docs together is pretty rough sometimes, with our schedules.
It is. I mean, I just finished working just about an hour ago. I finished. So, you're right. It always is kind of hard for two docs to get together, but somehow we managed to do it today. And I'm super happy to be chatting with you. I gave the audience a little bit of a background about yourself, but can you kind of give the audience maybe a little bit more of a background about yourself before we get started?
Yeah, so most of the time now I'm focused on, I come from 18 years in standard practice, insurance model, all that stuff. And in 2020 now, I stepped out and did my own thing, not knowing this whole lockdown COVID thing was going to happen. So, I was realizing at the time that I was really focusing more on diabetes management and trying to get people off of meds. And, in the standard model, it's hard to do because having time for education when you have a 12-minute visit, you really can't educate people. And I have a long history of obesity in my family and diabetes, and so I struggle with gaining weight and working long hours and being stressed all the time and always being in a hurry. And ultimately I found Jason Fung through a patient of mine who had lost weight doing intermittent fasting and a ketogenic diet. And I said, well, I'll look into this crazy stuff and see. And, at first I watched one of Jason's videos and I go, what's he selling? He's not selling anything. This is weird. And he just really wanted to help patients. So I really had to learn about insulin resistance and diabetes and the whole metabolic syndrome. And then, jumping from one thing to another, I started looking at Ben Bikman, who's a professor at BYU, and talking about life stress and sleep and, not drinking too much and exercise and all these big things of metabolic health. And so I jumped ship and started doing direct primary care. Well, I have an hour with my patients and we can talk about life and what's happening and not just throw another pill for high blood pressure and all that kind of stuff. So my quality of life has improved dramatically and my healthcare for my patients has gone up dramatically. I can be a lot more effective rather than, in the standard model, we try to be more efficient and see more and more patients all the time. And in that we lose track of what we're trying to do. And, divorces and life stress and all these things, people don't want to talk about it because you open a bag of worms and you have like 3 minutes to talk. So that's basically what I'm doing now, is really focusing on the metabolic aspect of patients and helping them to get healthier so that they don't have to see me all the time.
Awesome. Well, I think a lot of patients, are very, very happy to hear that. And I bet a lot of people listening are happy to hear that too, because, patients do want, more time with their physician, I think. And I think they do want, more of a personalized medical experience as opposed to, just kind of giving out the same standard prescriptions for different people. But it's interesting too, though, that I know your work, because I follow you on Twitter, is mostly with, metabolic disease. And so, right now, I'm sure you've seen the stats too. It's come out a couple times where like 12% of people or something like that in the United States or North America, I forget where it was, are metabolically healthy. So, first of all, can you kind of just explain for people what being metabolically healthy means and why are we doing such a poor job of it?
Yeah, it's pretty complicated. Really, when we look at a lot of different factors, metabolic syndrome, they'll call it, or syndrome X, they call it for a while. And you start looking at all these different parameters, one being high blood pressure, central obesity, high visceral fat, high insulin levels, but most doctors don't check an insulin level, high triglycerides, low HDL cholesterol. And it seems like in Western medicine, we just look at LDL cholesterol. So really what metabolic disease is looking at, all these factors. What Ben Bikman in his lab showed, the big thing, and this is what really woke me up, is I met with Ben one time. And I was at the gym before a long, one of these medical conferences is going to go on all day. So I'm trying to get a quick workout. And Ben Bikman's there, who's the genius of this stuff. And, I was kind of embarrassed. And I said, hey. And he goes, hey, Brian. And I said, how do you know my name? Because I was kind of new to all this stuff. He goes, I listen to your podcast. I was like, oh, this science. I'm a little stressed now. So he goes, no, I love it. He goes, you guys are doing a great job. And anyways, I said, Ben, look, since we're friends, if I want to live a long time, what do I got to do? He goes, oh, Brian, that's easy. 5 things, right? He goes, it breaks down to these 5 things. He goes, number 1, don't be working working 18-hour days and being stressed all the time. And I'm like, okay, I'm kind of doing that. He goes, number 2, get enough sleep. And I was waking up at 4:30 in the morning to go do my hospital rounds and then be in clinic all day and getting home at 8 that night. I'm like, Ben, I don't think I like your rules. I'm 0 for 2, right? He goes, that's why doctors die before everyone else, right? He was kind of making that point. That's why I'm not a medical doctor and he's a PhD doc. So, and he goes, okay, don't smoke or drink to excess, eat real food, cut out the processed food, right? And exercise regularly like we're doing now. He goes, that's what you have control over. Everything else is luck of the draw, you know? And so you start looking at that going, man, this metabolic disease. And that's why my company was called Low-Carb MD after the podcast. And I'm like, it's not just low carb, because there's people doing low carb, cutting out processed food, but they're stressed and not sleeping and they're bitter with the world, right? And not exercising. Like, it's a whole spectrum of things we have to address. So we just go, eat this meal plan and you're going to be fine. It's like, well, they're going through a divorce, they're stressed. And, you know, that's one of the points we came up. A lot of these guys who study obesity, they're studying mice, but they're not going through divorce, getting laid off, you know, their car got repossessed and all these things that we're dealing with that lead us back down that bad path of poor foods that just make us get at that high for a minute. And then we don't address the underlying root cause of what's happening.
Yeah, I mean, there's definitely a lot of physicians, unfortunately, who do fall into that, you know, poor lifestyle. And, you know, I think it's good for physicians like yourself to be talking about that, because I think we need more and more physicians discussing it so that, you know, more and more physicians can lead a healthier lifestyle. And if you have physicians leading a healthier lifestyle, then just, you know, by leading by example, your patients can potentially follow, you know? And so I think that, you know, that's a fantastic thing that, that you guys are doing there. You know, I just wanted to get into some of the, nitty gritty a little bit about, you know, some of the, risk factors and stuff for metabolic disease, like hemoglobin A1C, LDL, and all that kind of stuff. But, if someone does have metabolic disease, obviously they're at risk, or depending on what definition you look at, they would already have diabetes, you know, elevated waist circumference. And so when someone is, you know, metabolically unhealthy, what are they mostly at risk of acquiring?
Man, if you look at metabolic disease, I mean, I don't know of any illness that isn't associated with it. You know, Ben Bickman has a great graph looking at there. You know, he has a diagram showing cancer, tons of cancers associated with metabolic, and not only associated, but causally related to high insulin levels, right? So, there's a constantly, you know, we look at dementia, cardiac disease, strokes, erectile dysfunction, polycystic ovary disease. I could go through the list, hypertension, and all these are associated with high insulin levels, or causally from high insulin. So as if throwing a pill for this, a pill for your high blood pressure, one pill for depression, one pill for your memory problems, one for your heartburn. Why don't we just fix the underlying insulin problem, right? So, you know, having muscle mass, a guy like you have muscle mass, you're fit, you're active, you get your sleep, and guess what? Your insulin starts coming down. So a lot of us, what it is really, you know, people say, well, why does your body do that? Why do we get fat? Well, we get fat so we don't get diabetes. And some people don't have that luxury, and they could get diabetes when they're 140 pounds. So when I started seeing this stuff, I go, this is pretty crazy, because you think it's going to be the 350-pound person who's never exercised that gets diabetes. People of Indian and Asian descent would get diabetes, and they weighed 138 pounds, 142 pounds. I've seen it, but they eat so many carbohydrates their body can't tolerate. They have nowhere to put that extra energy, and they end up getting diabetes.
And are people with certain descents more likely to become metabolically dysfunctional?
Well, you know, I think at a lighter weight, I mean, all of us are predisposed to it, you know, if we don't take care of those 5 things, right? But some people, could get diabetes. You would be shocked. They get diabetes at 140, 150 pounds, and mostly of the Indian and Asian descent. But I have people in my practice, I'll see they're 450 pounds and they have hardly any visceral fat, which is an indicator of you know, this big belly. But if it's on the outside, they may not have metabolic disease, believe it or not. So you can't tell by just looking at someone. And so some people I look and I'm like, oh, they're healthy, they're fit, a guy looks like you, and then they have tons of visceral fat and they store it all inside where we can't see it. And people, they were healthy and they died. Well, they weren't healthy, they were pretty sick. So again, I see people who are 450 pounds, I get their insulin levels normal, their triglycerides are normal, their HDL, because they could store a bunch of that extra energy out in there where we can see it. But other people are storing in the visceral fat, and that's the one that's really associated with all the metabolic stuff we're talking about. So if you take someone who's obese, but they don't have visceral fat,
And visceral fat, for people who are listening, is fat are contained around the organs, and that's more dangerous than fat that would be in your belly.
Yeah, like fatty liver disease, fat around the organs, around the intestines, and it really affects with immune functioning. And so, yeah, you can't just look at someone like I'm surprised all the time. I go, wow, they're metabolically sick, or they could have. It looks like they're getting diabetes, and they just don't make enough insulin. So there's different problems, but that's why it's important to get a fasting insulin level, a 3-month sugar average, and lipid panel, all these things, so we can look and say, okay, there's a big picture we're painting, and not just look at one variable and go, oh, your LDL's high, because LDL doesn't mean anything to me by itself. It's what it's sitting in, right?
So your body composition does not necessarily then indicate whether you are metabolically healthy or not, correct?
Well, your body composition does matter, but it's where, just looking at someone. So looking at like a DEXA scan, or I use a Sika, where we can look at visceral fat. So if it's high, I already know the insulin level is going to be high. They're metabolically sick, right? When you're visceral fat, the fat around the organ. So,
and you can only get that through a DEXA machine. Is that correct?
Well, you can do it through a lot of stuff, CAT scans, and they're really looking at the fat around the organ. So there's some great studies we can look at. If someone has a lot of muscle tone, a lot of times they have no visceral fat, even though they're big. Like someone like Sean Baker, for instance, he has tons of muscle mass and he has no visceral fat. And so you go, okay, this guy's metabolically healthy, right? You can look at that, and so the love handle fat, the fat around the butt and hips, the stuff we can see, doesn't increase risk of atherosclerosis, cardiac disease, and it's not pro-inflammatory. So the point is, if we all went and got liposuction and take 40 pounds of subcutaneous fat out, it increases your cardiac mortality, because now all that extra fat you eat has to go to your visceral fat, which is the dangerous one, which is pro-inflammatory, pro-atherosclerotic, and increase your risk of clots and all that kind of stuff. So trying to minimize that is the way to go.
Okay. So if someone wants to get metabolically healthy, and probably be two parts to this question. So one of them is, the general clinical parameters. So if someone is metabolically healthy to you, what's their hemoglobin A1C?
Well, it really depends on the person, because the A1C by itself, I'm looking at the A1C with the insulin level. For instance, I have a guy, I just got his labs back. His A1C is 4.8, which is that's great. Which is great, but his insulin level is 61, right? Okay. So his body is cranking out a ton of insulin to keep his sugars down, and is doing a good job right now. He's only 27, but this is non-sustainable. A healthy insulin would be less than 5 ideally, but less than 10 is manageable. But this guy's at 61. Like it's like you have everyone working their tails off to hide that sugar somewhere. They're going to run out of place pretty soon.
Okay, so I do want to come back to the visceral fat and just sort of have a separate question or discussion about that. But in terms of like the clinical parameters that people can order on their blood work, like what do you think people should be ordering on their blood work if they're concerned about their metabolic health?
Yeah, number one, I would look at a lipid panel. If you have really high triglycerides, we used to think, oh, don't worry about triglycerides, because we found that when we treated triglycerides and lowered them, people didn't do better from a cardiac standpoint. Well, it's a marker of disease. It's not the cause necessarily, right? So high triglycerides are going to be associated with alcohol intake, for instance, a lot of fried food and fatty foods. And usually what happens is the triglycerides go way up and the HDL goes way down. So when we see that combination, think, oh, something metabolically is going on. So the analogy I use is like if you can think of a train. So if you have a train that has 100 seats on it, for breakfast, you're not eating a lot of carbs. Say you had eggs for breakfast. No, it's really the sugar that's getting on that train, which is your liver. So once you fill your liver up completely, what happens? Your body says, let's make the insulin go higher and shove more of that sugar into the liver as a storage place, right? So when I say liver, I'm talking about liver and visceral fat. But once that gets full, your train is full. You can't put more people onto a full train once you fill it up. So what do? You start putting people on top of the train. So you get fatty liver disease, which is a precursor. So looking at an ultrasound of the liver, for instance, you'll see a lot of fat deposits there, or a CAT scan, or whatever imaging modality you use. You'll say, oh, incidentally, this person has fatty liver disease.
And Brian, just to interrupt you just for a sec, with the fatty liver disease, if someone may actually develop a fatty liver before their liver enzymes are elevated. Is that correct?
Correct. Yeah. And so it's not, and even if they're losing fat around their liver, the liver enzymes can go really high when people are losing weight and getting healthier. So the liver enzymes themselves, but you're looking at that whole picture, the triglycerides should be coming down as you're getting metabolically healthier. HDL goes up, your insulin level starts coming down, your A1C, 3-month sugar average starts coming down. So it's really a constellation of all those things. And the other thing is high insulin level, people don't realize, is high insulin causes sodium retention in the kidneys and raises blood pressure. So when someone lowers their insulin down, their blood pressure gets better. Their inflammatory markers get better. The CRP, a lot of people talk about, gets better.
CRP is really important. So CRP is C-reactive protein. It's a marker of inflammation. I just say this, Brian, just because my audience may not be as knowledgeable as yours. Not everyone knows what CRP is. So that's why I kind of keep interjecting with these little points. But go ahead.
Yeah, no, I appreciate that because my wife will say that you guys talk so complicated. Sometimes Tro and I get caught up in the minutia of stuff, and we miss the big point. But really, it's that is saying, okay, how do I minimize my insulin? How do I get metabolically healthier? Well, one thing is you could have a lot of muscle mass, right? These big muscle guys, they could get away with Twinkies and donuts because that sugar is going to their muscles at least for a while. But then you hurt yourself, and then you gain a bunch of weight, and you get diabetes, right? So yeah, there's a lot of other factors involved. So if you don't have a lot of visceral fat, for instance, like when we're younger, those of us who've been thin growing up, I never had that luxury, but being overweight, you're already metabolically sicker. So you're kind of set up because what happens is when you have more visceral fat, when you eat, more of that energy goes to the visceral fat because it's less resistance, especially if you're not exercising. And that's why all these things play a role. This is why Ben Bickman, I love what he's talking about because he's true. The higher your insulin goes, we all know if you want to take someone who's the skinniest person and in one arm you give them insulin, the other one you give them sugar. All that insulin does is stores fat. And so all that sugar leaves the bloodstream and your blood sugars look great, but you're killing yourself. So that's why a lot of people say, well, that's what's happened in the old school of medicine. We believed, okay, you have high sugars, we'll put you on insulin. You can eat whatever you want. You like cake? Sure, just shoot more insulin. You want cookies and donuts and soda? Yeah, just shoot more insulin. I've seen people just get destroyed by this mentality because insulin does not make the sugar disappear. It just hides it from the bloodstream. So if I take it and I shove it into your liver and I check your blood and I go, look, your sugar, you're getting healthier, but you're dying because you're filling up all your fat stores and you're clogging your arteries and you're causing all these troubles, right?
Right. So you went over a few things there. So if you want to be metabolically healthy, first of all, it seems like the fasting insulin for you is a major important test, correct?
Correct. Yes.
Okay, so fasting insulin, you want low fasting insulin, you want low triglycerides, you want high HDL, and then waist circumference, I imagine you also want to be low as well, correct?
Correct. Yes.
And then so one thing, the only thing that we didn't mention there was that some people are probably wondering about is LDL or ApoB. Do you have much concern if someone has, say, if all their other parameters that we just discussed are good, but they have a high LDL? Would you think that that person is a candidate for a statin then, or would you say, you know what, you're metabolically pretty healthy, and say their other risk factors are pretty good too? Say their blood pressure is controlled and they exercise, they all that kind of stuff. Would you say, you're probably not a candidate for a statin?
Yeah, I like to get a coronary calcium as a baseline. If we're going to change lifestyle, I like to look and say, is there disease there or not? Because if there is, I want to document that, and I want to make sure there's no progression of disease, right? Because the jury's not out on all this stuff. Right. And so if I see an elevated C-reactive protein, right? We know inflammation in itself, whether you get sick, whether you get, spike protein you keep making in your body, whatever it is, whenever you have or an autoimmune disease or gut problems, when you see a chronically elevated CRP, it's concerning because we need to know why. Like, you shouldn't have the fire alarms going off all day. There's some reason why you're having this. So figuring out that problem. So statin drugs do decrease inflammation in the coronary vessels, and that's by probably the biggest mechanism they work, not absolutely just lowering your LDL cholesterol as low as you can possibly get it. So it's really looking at that patient. So if I have a diabetic with high sugars, high insulin, like all their metabolic syndrome is terrible and they're not going to change lifestyle, I'll say, yeah, I'd go on a statin drug. Right? That's a no-brainer because the LDL cholesterol cannot be sitting in a high sugar, high insulin, high stress, high cortisol situation. It's gonna cause you trouble down the road at some point. So if I can fix everything else, all the other variables, I'm not going to be as worried about. Say, let's work on those variables, unless you have a really high coronary calcium, and that may shift us that way, or a high inflammatory marker.
Okay. Okay, understood. What about ApoB? Would you think that people should order an ApoB over LDL? Do you think that that's a little bit getting into not semantics, but like, your LDL is probably good enough?
Yeah, I think when when you're looking at the LDL in the setting of the triglycerides, HDL, all these other things, I have people make strong arguments that it doesn't really matter. Because a lot of times, some of these things, it doesn't make a difference. It doesn't change much with medical management or lifestyle as much even. Some people genetically are going to have a high ApoB. So really, we're looking at that. If I have a coronary calcium score and I know that person's working out and taking care of themselves and watching their stress and getting their sleep, I feel pretty dang good about it, that I don't need a huge test. And I'm in a situation where I do direct primary care, which means a lot of my patients either maybe don't have their labs covered. So it's a lot cheaper for us to get, routine lipid panel, inflammatory markers, for, $89, we can get a great lab panel and really tell us what's going on. And some people, if they have a ton of cardiac risk in their family and everyone in their family dropped dead at a young age, then you're going to look at these more, the breakdowns of the big fluffy LDL, the small dense LDL, and really be able to give a good risk stratification, but when we look at the MESA scores, what we use for the coronary calcium, it doesn't factor in any of those other things.
Okay. Do you order the Lp(a) test as well for people?
Yeah, at times we do. Some people a lot of my patients are very savvy and they've been around and they go, okay, I want this whole lab panel. And other people go,
what?
Peter
Attia. That's the reason why so many people are ordering an Lp(a), as far as I can tell anyway. But sorry, go ahead there, Brian.
Yeah, and I think, at some of these things you go, okay, let's look at the big picture. Like, we know the biggest risk factor by far is metabolic disease, in diabetes. Like, you look at diabetes and all the things that it causes that come with it, all the way from amputations, kidney failure, blindness, you name it, across the board, non-healing ulcers. So if we can fix that problem, I think that's got to be our primary focus, because we know that's not even questionable. This is something we can monitor. We can monitor with continuous glucose monitors. We can follow the A1C. We can check insulin levels. We can look at visceral fat levels over time, and see what's happening. And so, yeah, I think it's just some people are going to really want the science and the numbers, but practically a lot of times it doesn't make a difference.
So I want to get back to just a couple more questions about statins, actually. So, and I ask this question of basically every doctor who comes on my podcast, because it's such a big topic. Like, it's one of the most widely prescribed drugs in the world. Heart disease is the biggest killer in the world. So, like, I always figure it's good to ask, different doctors about their opinions about this. So, statins, you're a low carb MD guy. You did just say, though, that, potentially you would, advocate someone to put on a statin in a certain situation, which I agree with as well. The only thing that people will say to that, and like I've read some other reviews, I'm sure you've read them too, like what do you make of these reviews that indicate that people who use statins don't have a longer life, and that statins don't prolong life, and that, people who take statins, it doesn't cause a decrease in primary prevention of cardiovascular events? Like, do you feel that mostly these studies are just done on people who have unhealthy lifestyle, and potentially the statin is actually, extending their life and potentially decreasing their overall risk factors? Or do you feel that maybe they don't work as much as we thought they did?
Yeah, I think the more I'm around, the more I'm saying, gosh, it doesn't work as well as we thought it did, right? And it depends on the setting again, so I look and I'm saying, okay, what are your risks going on? And most of the time we're protecting ourselves, because, if you have someone with high LDL cholesterol, metabolically sick, and you don't treat the statin with the statin drug, you're outside the standard of care, right? Yeah. So you go, okay, from a practical standpoint for primary prevention, do we have data on that? We don't have good data. So if someone's a young, healthy person with high LDL by itself, you say, well, what are your risks? And then we get the coronary calcium. We feel really good if it's a 0 score. But, it's such the way I feel the same way as I would about insulin. So if you put someone on insulin, you never say change lifestyle, I think that's malpractice. And I think if you put someone with pre-diabetes or diabetes on a statin drug and never talk about lifestyle change, I think it's malpractice. because the statin doesn't keep you from getting a heart attack. It decreases your risk a little bit. But if you're eating pro-inflammatory stuff all the time and you never exercise and you fight with your wife every night and you're a bitter person, like we have data on this. I just gave a talk and I was looking at a place called Roseto, Pennsylvania. And back in the 50s when Eisenhower had his heart attack, everyone said, oh, we got to look at this and take it serious. So they went around the United States. Of course, in the 50s, they didn't have statin drugs yet, right? So, and Eisenhower, by the way, was smoking 2 or 3 packs a day and having 15 or 20 cups of coffee and highly stressed all the time and didn't sleep. And he had all these risk factors.
But I heard he quit cold turkey.
Yeah.
I heard.
Yeah.
Yeah. Anyway,
he did. Yeah, he did. But once the damage is done, right? So it's like, yeah, okay. So anyways, they find this little place, 1,600 people in Pennsylvania. And guess what? They're Italian immigrants. And they have the lowest incidence of cardiovascular disease. Their seniors over 65 had half the mortality of anywhere else in the U.S. And no one under the age of 55 had a heart attack in this community. And so they went through all the numbers. Their cholesterol was no different than anywhere else. Their weight was no different. They might have even been a little heavier. They smoked cigars. They drank wine. They ate Italian food. So I was like, what are they doing? So 7 years of this study, they found that they had community. They were laughing. They helped each other. The grandparents and the parents and the kids and the grandkids all lived in the same house. So they said, hey, you guys go out to dinner. We'll watch the kids. Marital stuff. And they respected the seniors. And 85% of the people in the town were in some kind of group. They either went to church or bocce ball or bingo. So they had community involvement. And when you look at the data, you go, look, if you take a 65-year-old and you have them do choir practice once a week, it decreased their overall mortality. Their self-reported health was better. They had fewer doctor's visits just for that. It's not like they're getting a big workout at choir practice, but they went to where places people knew them and they had friends and the people said, oh, I'm sorry you had a hard week. Oh, let me put my arm around you, whatever. How are your kids doing? And so this sense of community, if we forget that in medicine, I think what's happening is we become, even doctors nowadays, don't have a relationship with their patients anymore because they're like, okay, I got to get you through. I got 8 minutes. I got to write my note. I got to deal with the insurance company. And so we've lost that connection where someone cares about you and puts their hand on you and says, hey, I got you. Right. And that's what we're talking about is like, and again, we know that statins can increase sugar levels and insulin levels and make metabolic disease worse. So we still have to address metabolic disease no matter how we cut it. Right. Yeah. So I choose let's address the metabolic disease. Then we can worry about a statin later because some people, there's lean mass hyperresponders. They get so skinny that all of a sudden their body's kicking all this cholesterol that was stored in their fat stores because they need energy to burn. Right. So if we want to lower their, like there's a study that's going out, it's almost a ridiculous study, but Nick Norwitz is doing it with Oreo cookies.
Okay.
And he's a lean mass hyperresponder, and he's lowering his LDL by eating Oreos. Does that mean it's a good idea? Of course, he's not making that point. He's just saying, look, lowering the LDL does not mean you're healthier necessarily, especially when you're looking at seniors and you go, okay, if a senior has higher LDL, their all-cause mortality drops. Their immune function's better. But there's a lot of confounders with cancers and all these different things of, being malnourished But, what I'm getting at is it takes the whole picture. That's what we get paid to do is say, okay, look, let me see what's most likely to kill my patient. And let me address those things first. So if you're drinking a gallon of vodka every night, I'm probably not going to say, hey, let's put you on a statin drug and you keep doing that. Right? It's not going to help you out of the situation. You got to get that gallon of vodka gone. And then we worry about all the other stuff.
Yeah, I think that's a perfect answer to the question. I mean, obviously, heart disease is a very, very complex and multifactorial disease, and it does need to be looked at on an individual level. But at the same time, I think you did a very good job of explaining, a lot of the blood tests that people should order and what their levels approximately should be. So I appreciate you doing that. One question, I have another pharmaceutical question though for you too on the topic of hemoglobin A1C. So, I see patients and when I see a hemoglobin A1C of 5.5 or 5.6, especially in someone who's, younger, like these people are not even close to being diabetic. Like just for the audience reference range, like 6.5 is considered to be diabetic, 6.0 to 6.4 is pre-diabetic, and then 5.5 to 5.9 they say is at risk. But generally speaking, I'm not, shitting on other doctors or anything, but I think that if someone's hemoglobin A1C is 5.9 and they're 20 years old, they're like, you're normal. It's like, that's not normal. Like, you're 0.1 of a point away from becoming pre-diabetic at 20 years old, and then in a few years you become, full-blown diabetic. So, I guess I'm going to ask you two questions here. So, what cutoff do you think is ideal for people? And again, you give us a range there because everyone is different. And then also too, when would you potentially initiate metformin, and would you potentially suggest berberine instead of metformin? I know that's kind of a lot to unpack there.
Yeah, and I think the example I gave, I don't look at the absolute. I'm looking at the insulin level and the A1C. So, for instance, this guy whose A1C is 4.8, almost 100% of doctors go, you're never going to get diabetes, you're fine. When I see his insulin is 61 or 62, I'm like, you're a disaster waiting to happen. So looking at it in context, because I know it's like, if you're running on the treadmill and you're going fast, I know you can't maintain that speed. If you're running at max speed, you can't run it for an hour. You can only max out for so long. So when I see that pancreas cranking out insulin like that, I go, you're in trouble. You're in major trouble. And it's coming. I don't care what your A1C is at that point. You're in trouble. It's gonna come. So yeah, and I would agree with you, trying to keep that A1C as low as you can, through all these lifestyle things we're talking about, but also realizing that you can have an A1C, or for instance, I have some people, it's not necessarily just about having a good, so for instance, if I see someone with a high insulin level, it said their A1C is at 7 and their insulin's at 2. I don't feel good about that. They're a disaster. Like, they can't make enough insulin to get they should be cranking up the air conditioner to cool it down, but they're not. So there's a reason. We got to figure that out, right? So sometimes people just don't make enough insulin, and some people are really, really insulin resistant. So sometimes it's more of a relative insulin resistance, meaning, like, I have a guy today, his A1C is 6 or 5.9, and his insulin's like, 6.
So for that guy, you're not as worried about him kind of going off the rails because his insulin is so low overall.
Well, the point is, he can't mount a more of it, because he should be, if you think about it, if your A1C is like 6, your insulin should be higher to bring that down. So when I see it low, I go, you can't get your insulin higher than 6 for some reason. It's either you're stressed, you're not sleeping, you're bitter, you have a bunch of cortisol floating around. Something's going on, because that insulin. So what does he do? He puts on muscle mass, and he'll bring his A1C down.
Would you put him on metformin or berberine?
Actually, I have him on berberine, and I have him on to start. And that goes back to your question on metformin and berberine. Yeah, I don't think everyone needs to be on metformin. It's like, okay, if we can ideally, what's metformin doing is decreasing your sugar release from your liver, and also making your muscles a little bit more sensitive to insulin. So guess what? Exercise. If you're not exercising, you put on some muscle mass, and it lowers it's going to do a better job than berberine or metformin will do. If you're making enough insulin to shut down this glucagon response, right, to release extra sugar. Yeah. So yeah, I think most of us, because I mean, if you're playing the odds, like you astutely mentioned at the beginning, was that if between 7 and 12% of us are metabolically healthy, probably the rest of us would benefit from berberine or metformin, probably, right? Yeah. Depending on how metabolically sick we are. So apple cider vinegar is another one that people, have. I always thought it was just crazy, but I'm looking at data on that where they're actually getting improvement in insulin sensitivity by having a little apple cider vinegar and water a couple times a day. It's not that I don't enjoy it, but sometimes it does help to bring those insulin sugars down.
That's good, because it's cheap too. Very cheap.
It's cheap, and it looks like it works in the gut microbiome, like berberine does. It's not the effect it has. It's really helping the gut. It has an anti-inflammatory effect, and also helps with your, help preserve some of your gut microbiome and insulin sensitivity. So, but watching your stress, getting sleep, all these things benefit. So it's not just saying, oh, I'm just going to change my diet and forget about those other things that are part of this whole metabolic panel.
Yeah, at the beginning of the show, when you were talking about, Ben Bickman's Big Five, I was so happy actually that you said sleep, because I think sleep is probably even more important than diet and exercise, which is like, I thought everything, especially growing up, as like a young guy who's working out, it's like, it's all about diet and exercise. That's it. That's all you need. You just do that, you'll be good. But it's like, sleep is literally the most important thing. And do you see a lot of your patients, when they have poor sleep, basically everything else is, falls apart, and then when they get good sleep, everything comes together?
I'll give you an example. I mean, thanks for raising that point because it's so critical. I was at a low-carb conference, and one of the big guys who I respect a lot said, sleep doesn't matter, it's overrated. I was like, I don't think so. And so, I started looking at it, and it's crazy. One of my guys, get this, you'll appreciate this. I've been taking care of this guy for 19 years, right? 20 years now, 20 years. So for 19 years, the guy's weighed between 180, 182 pounds. He's never had obesity, diabetes, pre-diabetes, none of that stuff. It's just a fit guy, active, like low stress. He retired before I met him. Anyways, for 19 years, he weighs so last year I saw him for his physical, he was 180 pounds. This year I see him for his physical, 203. This is after the lockdown. So I'm like, wait a minute, you went through the lockdowns, you had no weight gain. Now all of a sudden, after that, you gain 23 pounds in a year after not gaining a pound for 19 years. Well, this clearly isn't genetic. Right. So he goes, Doc, I'm paying you. You tell me why. And I go, okay, look, let's go through Ben's 5 things. So I go, okay, number one, you start eating dessert every night and you're eating cookies and donuts and you change your diet. He goes, didn't change my diet. I'm not a food person. Okay. Number two, you hurt yourself and stopped exercising because I know you're a fit guy. He goes, no, do the same workout, same trainer, same everything. I was like, okay. You start drinking. You're drinking like margaritas now and Mai Tais or something. He goes, no, drink a couple glasses of wine a week and that's it. So I was like, man. The only 2 things left are stress and sleep. He goes, bingo, you got it. That's why I pay you the money. I go, tell me about it. He goes, well, this year my mom turned 99. She got severe dementia. I moved home to help her. He goes, 4 times a night, I'm up changing her diapers, making sure she goes to the bathroom okay. All day long, I'm like following her to make sure she doesn't fall and break a hip. He goes, he's a single guy who like flies to Paso Robles to learn how to make wine, and he goes to Texas to learn about regenerative agriculture. Like, this guy just does whatever he wants. He has no responsibility. And he goes, now I'm up 4 or 5 times a night. I'm watching mom all the time. I'm worried. He goes, I can't think right. And he's 73 years old. So it's not like, he was from 53 to 72. He didn't gain a pound, and all of a sudden he gains 23 in the year. And he goes, man. So we talked about it, and I go, man, I think it's the stress and sleep. That's got to be what it is. And you're probably eating more than you think. He goes, no, I don't think so. I'm pretty much a creature of habit. So anyways, we talk about it and I go, you're going to need some help at home. You got to figure this out with mom. You're not built for this stress. Too. So guess what? 2 weeks later, the guy gets a caregiver 3 nights a week. He loses 8 pounds in 2 weeks with no other changes. And you go, okay, tell me sleep doesn't matter and stress and all these things. So that's when I really started looking at the effects of stress and sleep. And there's studies. I read a big study that showed if someone's eating 1,000 calories a day, right, a calorie restricted diet, and they're sleeping 4 hours a night, a majority of their weight loss is muscle mass. If they're sleeping 8 hours a night, the same people, a majority of their weight loss is fat mass. So losing muscle mass is not a good weight loss strategy, right?
Yeah, that is such a good, important point though for people to know, because if you're if you're trying to lose weight and then you're not sleeping well and you're just losing muscle, obviously that's got to be very, very frustrating. So, if your sleep is not up to par and you're trying to lose weight, definitely try to, do something to decrease stress to make sure that your sleep hygiene is on point so that you do get a good night's sleep so that you can, potentially give yourself the opportunity at least to become metabolically healthy. Because if you don't, sleep well, you're not even kind of giving yourself that opportunity, it seems like.
Yeah. And, along those lines, just quickly, is that when I was looking at this data, I was really surprised because I wasn't surprised because I knew it, because inherently we know when we're up all night in the ICU, stressed out, the next day you could eat shoes and you don't care. You're so hungry. So I was like, and I told my wife at the time, I said, how can it be that I'm starving and everyone else is like me? The skinny people are eating all day. And now I'm seeing the studies showing, your satiety hormones go way down, your hunger hormones go way up, and you override, when you're fatigued, you override your frontal control over what you eat. So you crave more sugar and fat together as a natural coping mechanism. And it's documented. So it's not like you can go 3 hours a night and not sleep and not be craving sugar and when saying, forget it, I'm going to, and then you're more likely to drink because you're stressed. And then you get into this big cycle, and that's why when you're talking about CBD and things like that, you go, okay, if I can break the stress and sleep cycle, patients will do a lot better, because we know, Troy and I have talked about it for 5 years. Number one reason for failing a lifestyle is stress. Number two is lack of family support. So those things go together. If you have lack of family support, you're probably stressed too, because people don't have your best interests at heart and things like that. So yeah, it's pretty amazing that if we can get the nerves better. And that's why we tilted towards the low carb diet, because when you cut out sugar and processed foods, it seems like people's stress levels get better and their cravings get better, and they go, oh, this is easy. I'm not like white knuckling and doing willpower, like starving myself all day, you know? So those kind of things are what we're seeing. And you get the stress and the sleep and all these other things it's a snowball effect going the right way. It's like a country song backwards, you know? You start getting life better and you get more control back in your life.
And most foods too that are either high in fat or high in carbohydrates, most natural foods are only high in one of them. Like if you look at something like, you know, fruit, for example, you know, some people, you know, demonize fruit. I think that's ridiculous. I eat berries every day. I mean, I understand you shouldn't go overboard with it, but I think having, you know, a couple cups of berries every day is very, very healthy. But it's the foods that are created, like the packaged processed foods that have both high fat and high carbohydrate. You know, like if you look at, you know, the traditional foods with high fat, whether it's, you know, a fatty meat or something else, that doesn't have also high carbohydrates. And then when you look at high carb foods, you know, if you look at something like pasta, it's lower in fat overall. It's really mostly these, you know, processed foods that people are eating that we've created, because when you put fat and sugar together, you know, most of the time it does taste good, right? So then people create it more and more. But yeah, sorry, you want to go ahead.
And that absolutely makes sense of why you crave those things. So if you're sleeping 4 hours a night, you're telling your body you're the worst hunter on earth, right? Because you're up all night, but you're not killing anything. So then you want to eat more, and your body says, let's get rid of muscle, because otherwise you're going to lose all your fat stores and die, because you're that bad of a hunter. If you're sleeping 8 hours, your body assumes like, oh, you're trying to, you know, you're resting. You're not too worried about not killing anything. So yeah, and so your body goes, okay, let's get the most bang for our buck, fat and carbohydrate together. You can get a lot of calories and you can store fat to survive longer. So unfortunately, a lot of us are like bears. We're trying to wait to hibernate, but we don't hibernate. So we have to get rid of that extra fat. Trust me, I've been dealing with that my entire life. So yeah, you're trying to get rid of that visceral fat. How do you get rid of it? You put on muscle mass. Like, it is rare. I mean, I'm telling you, I don't think I've seen it where someone has a lot of muscle mass and a lot of visceral fat. It just doesn't go together. I mean, because the muscle mass inhibits visceral fat. And like a bear, when they're going to hibernate, what do? They get rid of their muscle and they put a bunch of fat on. So why? You could sleep for 3 months without having to wake up. But if you're like Arnold Schwarzenegger bear, right, and you have no visceral fat, how long are you going to sleep for? You can't. You're going to run out of energy. You know, so they get rid of the muscle mass and store visceral fat, and it's definitely inhibitory. We see it for sure in our clinic all the time.
So if you are someone that has a ton of visceral fat, one way that you can decrease your visceral fat overall is to just add muscle mass.
Absolutely. Yeah. You put on muscle. The problem is, as we get older, like if I would have started this a long time ago, it would have been an easier road. But once you get a lot of visceral fat, now you got to, visceral fat inhibits muscle mass from going on, and muscle mass inhibits visceral fat. As a matter of fact, a guy I just saw today, he blew my mind and made me look at this stuff, because he came to me at 320 pounds. Right? Diabetes out of control with 4 pounds of weight loss. The guy reverses diabetes, comes off insulin, all of his meds. I'm like, how can that possibly be? 4 pounds of weight loss. His wife at that same time had lost like 38 pounds at the same, and she was 158 to start. I'm like, how can this possibly be? They're eating the same stuff, and he's more strict than she is. His sugar's normalized. So it turns out when we measured, like, they were happy as can be. I go, how could you be happy with 4 pounds of weight loss when you're 320 pounds to start with? You're 316. And he goes, my pants are falling off. My shirts are, I go, come on, man. Like, seriously. And he goes, his wife goes, trust me. Because before I used to, when I hugged him, I couldn't touch my fingertips. Now I can grab my wrists around him. So we measured him. He lost like 8 inches off his waist with 4 pounds of weight loss. You're like, how's that? Because he lost visceral fat and put on muscle mass within Dr. O'Meara has shown that on CT scans, where you put on muscle mass without even exercising, because your body, they're inhibiting each other. So you get rid of one and the other one gets better.
That's crazy. So, okay, I do want to talk to you, Leah, a little bit more about visceral fat, and mostly just on how to measure it. So from my understanding, and I mean, I hope this is not the case, because I've tried to get a DEXA scan kind of connected with myself in London, Ontario here, and I haven't really found any. But is that the only tool that you're aware of, or there are other tools, Brian, that do measure visceral fat? Is that correct?
Yeah, no, there's ways, like, you can approximate it, but okay. You know, I use what we call a Sika. It's a type of scale that does body impedance, and we can look at how much muscle mass you have, how much visceral fat you have, how much subcutaneous, and we can kind of follow that over time. Because some people, again, like I have a lady, she just gained 4 pounds since over the last 2 months. She gained 4 pounds, but she had a net muscle increase of 12 pounds. So she lost
Holy
8
shit.
pounds of fat with a 4-pound weight gain. And her clothes were falling off her. And she was upset when she got on the scale. I'm like, oh my gosh, look at your Sika and DEXA both matched up and said, look, you lost visceral fat, put on muscle mass. Doesn't get any better than that. You're getting metabolically healthier. So we're just so taught to focus on the scale that we missed the point. Like this guy who reverses his diabetes with 4 pounds of weight loss, like he had put on tons of muscle mass at the same time.
Yeah.
So now his sugar's under better control because he can now put on muscle. When your visceral fat is inhibiting you from putting muscle mass on, you're in a bad situation. That's
So
why
do you get all your patients then to measure their visceral fat like annually or something like that?
I own the machine, so I go, hey, just do it. While you're here, and it's like getting on the scale, and we can look at it, and people, it will either encourage them or maybe get them back on track if they've been, slacking a little bit.
It's a Sika scale, you said?
Yeah, it's Sika is the model that I use. Yeah.
Okay.
Yeah,
Cool.
and so it just does body impedance and really weight, BMI and all that stuff. But then when you start looking at, you can look at fluid status. There's so much stuff it can do, but the reality is like, I just care to see the visceral fat going down, muscle mass going up. Okay, you're healthier. And that's going to reflect in the insulin and all that. So you don't have to, Dr. Westman, all he did was put a string around people's waist and cut it. And then they would come back in a month, and then they would, like, he lives in a poor area of town, so they could just see that the waist circumference was coming down. They're getting healthier. They're losing visceral fat, right? So you don't need to have a fancy machine, but what I can tell you is when we see that visceral fat coming down, I guarantee their insulin's going to be better, their triglycerides are getting better, their HDL is getting better, everything's getting better because you don't have that huge inflammatory response still, because people don't realize visceral fat is a really high pro-inflammatory. That's why during COVID, we were seeing it was the morbidly obese diabetics who were dying, and it's because they were inflamed. And there's something called TRPBR2 that's only made in visceral fat. And in mice, when they blocked TRPBR2, they couldn't cause this cytokine storm, this massive inflammatory response. So yeah, and you look at that and you go, well, it makes sense. Like poorly controlled diabetics are the number one. They were the sickest ones in the hospital for sure. And everyone I talked to that treated these patients said, yeah, you got to control the sugars. If you don't, we can't help them no matter what drug we throw at them.
Okay, you're definitely teaching me something here now. So I kind of want to learn a little bit more about it. So visceral fat, that has something, that the mice produce called what again?
TRPBR2. I had never heard of it till I was that patient made me research visceral. I'm like, how can this guy lose 4 pounds and reverse all of his metabolic markers and his triglycerides? Everything got better with 4 pounds of weight loss. It's ridiculous. So yeah, you start realizing that visceral fat is different than subcutaneous fat. So his wife, what I'm getting at is his wife's like my wife. Back before I was low carb, we would gain weight during the holidays. Then you go, okay, and she would make my lunch and her lunch, my dinner. We eat the same thing. And she weighs like 140 pounds or something. I'm like, how am I gaining weight and she's losing weight eating the same thing? It doesn't make sense. And I work out 6 days a week. Like, it doesn't make sense. But she was metabolically healthy, so she just burned subcutaneous, which burns a lot quicker than visceral fats like oak you got to burn through. So once you store all that highly dense energy, it's hard to get through that. But you lose that first because it's the most dangerous stuff, right? And your body gets healthier even if you don't lose a pound.
Yeah, you've said a lot of good things this podcast. I do have more questions for it, but that is one thing that I think people will remember is get your visceral fat checked. And that if you do have high visceral fat, increase your muscle mass and get that down. Okay, really excellent point there on the visceral fat. I do want to come back to you were talking about earlier about a CT scan and a CAC score, so a calcium arterial. Can you finish that last C? What is it?
Coronary artery calcium score.
Okay. Coronary artery calcium score. So that's done with a CT scan. Now that will show the calcified plaque only, correct?
Correct.
Okay. Now, if you want to show the non-calcified plaque, the only way you can do that is to get a CT angiogram. Is that correct?
Yes.
Okay.
And that would be the gold standard. That would be the gold standard. But you can get a coronary calcium score as a rough screening for $100 here in San Diego, at least. And so angiogram is going to cost you $1,500, $2,000. So if someone's paying cash and the insurance doesn't cover it for the most part, so
yeah. And so the CAC, that'll tell you again how much calcified plaque that you actually have. So if you're someone who's developing plaque, then that won't come up on that particular test, correct?
Correct.
But if you're developing plaque, that'll come up on the CT angiogram. So the CT angiogram is a better test overall, but it's also way more expensive, way more invasive. And there is a little bit, it's not a crazy amount. I think Atia said it's about 4% of what you should get a year, but there is about 4% of your radiation exposure per year. I forget all the milli equivalents he was kind of spouting out on that, but it seemed to be, I remember that particular figure, about 4%. Okay, so in terms of ordering like an echocardiogram, like that would have significantly less value than the two tests that we just discussed, correct?
Yeah, if you're doing it as a screening test, really, I mean, a lot of these guys have done good work at looking at that, like a stress echo, for instance, right?
Okay.
We're looking at some of these tests are like an EKG, electrocardiogram, or an echo at rest. You're going to pick up stuff when you're at max exercise. So they'll do a chemical stress test or a nuclear stress test where they speed up the heart rate really fast. And they can see, oh, you're not getting the blood flow in this area. And they can say, oh, we got a problem we got to look at, right? So there's a lot, but there's a lot of controversy still around that, as far as like putting a stent in.
Stress tests?
Well, no, as far as intervening.
Oh, interventions. Okay.
Yeah. So the highest coronary calcium I've ever seen yet is in a vegan for a lot of years. And I was shocked. And but he's high stress, like really, but his insulin was normal. His markers look good. So when I saw that, I was like, oh my gosh. But I called the cardiologist. I go, hey, I don't want you just stenting this guy because he has a high coronary calcium score. And the guy ends up passing a stress test, does everything good. He's still doing fine. Like we're getting him to watch his stress and get his sleep and do all these other things. But it's one of those you want to see the dynamic studies to see, is there decreased blood flow? But one of them that Haseem Malhotra has brought up, who is a cardiologist in the UK, he said, look, awesome. George Bush Jr. rode his bike through the mountains for 3 days. He comes in on Monday. They do a stress test that was positive, but he was asymptomatic and they stuck stents in him. He goes, that's malpractice. And he's right. It's malpractice. If you're not having symptomatic relief, the stents, unless you have an acute heart attack, is different. He wasn't. And to stick stents in the president of the United States without, it's not going to prolong his, and he should have been consented to say, this won't prolong your life, but it's going to help prevent you from getting chest pain. He's like, oh, I'm not getting chest pain. Do I have to do it now? Is it going to prolong my life? No. Then people may have a different decision on whether they put a stent in or not, right? But if you're symptomatic and you're having chest pain every time you go to the mailbox, then that's an indication to have a stent.
Okay. All right. I know we have a few minutes left, but I didn't want to, have this conversation with you without talking a little bit about testosterone as well, because it certainly relates to metabolic health. And some people are, concerned about cardiovascular disease with testosterone. When I look at all the studies, Brian, I see that, low testosterone is actually linked to poor metabolic health, what we've been talking about today. And yes, if you do abuse testosterone, it can potentially have some, pretty serious side effects, including, elevated liver enzymes, distorted lipid panels, that kind of thing. But low testosterone in particular is bad for hemoglobin A1C, or your blood sugar. If you had some patients, with low T that had really high hemoglobin A1C, then maybe you fix their testosterone and they got a little bit better, healthier metabolically.
Yeah, it's funny. It's funny you bring this up because we may have a different perspective on this, right? So I had a lot of guys with low testosterone that were metabolically sick. So I was like, instead of replacing the testosterone right away, let's see what we can do with low carb and working out. And I have guys quadruple their testosterone by putting on muscle mass. It goes both ways though, because I can see it as a chicken and egg. So you go, okay, can I help this guy out with a little extra testosterone and get him working out better and stuff? So there's data, I think, on testosterone helping the quality of your workout so you can get it better. So if someone's never working out, but the thing is, you can't just take testosterone and never work out and think you're going to put on all this muscle mass and fix your metabolic health. So it goes both ways. It's the same thing I would say with the statin drug or insulin. You can't just put people on insulin and have them eat terrible food all the time. And you can't just go on testosterone and sit around and eat donuts all day. It's not going to help you. I mean, it may help your testosterone go up, but it's not going to help your metabolic health necessarily, unless you just are lucky. But this guy, we just recently had this conversation with, I go, look, you can't just take testosterone and think you're going to get all your muscles and you're going to be 22 years old again. But, and he goes, and I go, but you also can't want this huge dose of testosterone that you've never taken before and think you're just going to be, like Sean Baker. It doesn't work that way. And I go, yeah. I was making the point to him. I go, you can't plant a seed today and you're going to have fruit on that tree tomorrow. You got to put in the work. You got to put in the time. You got to till it. You got to watch it grow. And it's not going to just put a bunch of water and sun on it and you got a tree tomorrow. It's not going to happen. So, he kind of took that point, but I agree. There are some times when you go, okay, let's give them a little testosterone that maybe helps their energy and sex drive and mood and all these things to let them be more functional in the gym and get onto it. But yeah, it takes both though.
Yeah, and I think too, your approach your approach actually is the same as mine though. In fact, that like if someone has low T, like I don't think you should right away put them on testosterone. You should try the lifestyle interventions, some of the supplements. The two big ones would be Tongat Ali and then Vidotio agracius. I forget what it's called, and potentially to boron. There was one study in humans anyway that shows that it can lower SHBG, which would increase your free testosterone. So not too much of a sidebar here, but there's total and free testosterone, and there's something called SHBG. So if your total testosterone is high, but your free testosterone is low, and you probably have high SHBG, meaning that all your testosterone is being bound up. There's one study anyways that shows in humans that if you take boron, it can free up some of that total testosterone to free testosterone. So I know Huberman has talked a lot about Tongat Ali and Fidocia. I'm not sure if I'm saying the second one right or not, but I think there is potentially evidence for boron. But that would only apply though if you had high total and low free. So if you had a normal total and normal free, the boron may or may not help you in that particular situation. But yeah, I think that's the best way to do it. Try to with behavioral and supplements first, and then potentially if they're not responding, then you can use some testosterone, and that may in fact be helpful. So I completely agree with you on that.
No, thank you, man. That's why, like hormones, I'm like I call them the best experts and say, hey, manage this, right? I'll manage the metabolic stuff. We'll work together to really help the patient. So I think that's some things you just don't feel real comfortable with. And so, I think it's good to share the wealth with people and say, okay, let's all work together. And then we learn from each other, like what you're saying, some of these supplements, I hadn't heard of, using boron, things like that. So stuff I can look into too. So I appreciate that.
Yeah, I mean, I've learned so much here today from you, Brian. Dr. Jaime Seeman, who's on the podcast maybe a month or two ago, Dr. Fit and Fabulous, she goes by, she was talking a lot about visceral fat, and I was really looking around in my own area and I couldn't find a DEXA machine, but I'm going to look a little bit harder because I really want to know that number now for myself, and I want to be able to offer it to my patients as well. So I'm so glad that you chatted about that. But I really want to chat with you about metabolic health today. I thought we've had a fantastic discussion, but before we leave, can you tell everyone where they can find you online, where they can learn more about your podcast and whatever else you're doing?
Yeah, my podcast, they're both Low-Carb MD is like, we have a lot of downloads. It's been pretty good, and so that's everywhere, Spotify, wherever you listen to podcasts. And Life's Best Medicine is my new baby. I love it, because I get guys like you on and we talk about, hey, what got you into this? And, what was it? What do you do when everything sucks in life? And how do you pull through? And so some of the stories, Sean Baker is one of my favorite interviews ever. I was shocked at like what he's been through in life. You go, wow, okay, he's not just a loudmouth guy, he's got a lot of substance. And so all these people, it's amazing to hear the backstory of how do you get interested in this stuff,
Well, I'll have to listen to that one. That's Low Carb MD with Sean Baker.
No, that's Life's Best Medicine.
Oh, sorry.
Life's Best Medicine is more about the other stuff. So when I didn't talk low carb on Low Carb MD, if I talked about faith or whatever, exercise or sleep, people are like, we just want to hear about low carb. We don't want to hear about this. Well, it's all part of this whole metabolic thing. It's all part of it. Like if you're a jerk to everyone, you're not going to do well. Like why do you want to live longer if you don't get along and have fun a little bit in life? So it's those kind of things. They're talking about stuff that you're going to talk about, like sunlight and sun exposure and vitamin D, things like that you say, okay, these are other things I can do to get my health better, and so that. And I'm on Twitter a lot. I do have Instagram.
Share your Twitter handle.
It's at Brian Lenzkes, BrianLenzkes, Z as in zebra. And Yeah, and I have low carb. I mean, it used to be called Low Carb MD. I have San Diego Metabolic Health and Arizona Metabolic Health. Now I'm kind of transitioning out of California a little bit, and just trying to help more people online to do focus really on metabolic health and all the other stuff that matters.
That's awesome. Well, I love what you're doing. It's right up my alley. Again, you're one of my favorite follows on Twitter. I've had an amazing time chatting with you today. I definitely want to check out that podcast you did with Sean. That sounds very interesting. So thank you so much again for coming on today, Brian. I really, really appreciate it. Everyone who listened, thank you so much for listening. And as always, I'll be back again next week.
All right. Thanks for having me.